information. So welcome to pediatrics. You are, most of you, one semester away from the last one and becoming registered nurses. It is a rough semester if you're carrying those three courses, Med-Surg 2, Community, and Pediatrics. Community is not an easy course, and you're gonna have to put time in it. Most people felt like, community, it's not like that. It's taking and putting the concepts together and following patients home and all of those things in the community that they need to do for them. And it's really a lot of thinking. And pediatrics is just like Med-Surg 2, because it is a difficult Med-Surg program, but it's just on children. Now, the one thing that is lucky for you all, I've been a nurse for, I don't even want to say how long, because it shows really how old I am, but I don't feel that old yet. I've been a pediatric nurse for 28 years. And before that, I was an adult nurse. And as an adult nurse, I did ER, I did recovery room, I did all the floors, ICU, open heart, cardiac ICU, ICU. So my experiences are all over the place. And what that does, it helps me describe things to say, this is the difference between peds and adults, so that you're understanding. And I've been told that many of you are like, you taught me Med-Surg in a way I could understand, because Med-Surg is Med-Surg. There's just differences because of the ages. Now, tonight, we're gonna do three things. We're gonna go over the PowerPoint sent by Dean Brown, but you've already seen it once. So I'm just gonna go through and hit those highlights that I want you to understand for my course and those important things, even for community. And then I'm gonna do a Kahoots. And I'm gonna do a lecture on the information, which I've already sent you. And then I'm gonna do a Kahoots. Now I want you to pay attention to the Kahoots. Kahoots is a game, right? But it's an instant testing of your knowledge. But as I'm testing you, I'm explaining it as it goes. So hopefully you'll get it. So what I'd appreciate, come to class and do your interactive lecture on your modules. If that's all you can do, no readings, that's what I want you to do. So now you've seen it once. Come to class, get my lecture. That's the second time. And then I give you Kahoots. That's 3 points of reference that you've heard the same thing. And it has been said, even through research, that's how students learn better, okay? Any questions so far? Okay. Now, I am really easy to reach. I do answer emails, messages, and Canvas pretty quick. Also, let's say you're having an emergency or you're having like this moment, I want to know now, you can text me on my cell phone. Shouldn't be your first point of trying, but if you're having a moment, and I know you will, you can text me. And the phone number you can reach me is 305-951-8055. It is also on my biography, so you have it. So if you need to get hold of me quick, you're having a moment, you want to know now, text me. Or something happened, you can't get to class now, text me. That's the quickest way to get a hold of me.
All right, say that number one more time.
Sure, 305-951-8055.
Okay.
And I will answer. I'm usually at least till 9 o'clock at night, I'll answer. I don't do early mornings. I don't expect anything before 10. I am not that one who thinks in the morning. I worked 23 years of night shift. So I'm more of a late morning, early afternoon person, but I get back to you pretty quick. When you need me, I will be there. If you need me, you call me. All right, let's quick do our PowerPoint from Dr. Brown. And I am going to go over those things in it. That it's the same PowerPoint that you've seen in community, because you probably have already been to community, I would hope so. So just to let you know, I am the lead pediatric professor. So if you need anything, first come to me, ask me a question. If I am not getting to you quick enough, or something I do you don't like, or you need explanation, I say, please contact my dean. I will not be offended. Maybe I don't know something. Maybe it's something, that I should have gotten quicker, but I'm pretty quick. But if not, contact her. It's darlene.brown@fortiscollege.edu, and there's her phone number. And she answers really, really quickly. And I've been working with her now for over 2 years. I think she's fair. The reason why I am here is because of her, because she is professional and she really wants you to succeed just like I do. So if you don't want to talk to her, please talk to her. Not a problem. I've told you how to get a hold of me. When you're with me and you're online, just be professional. As in, don't wear outfits that that you go to a nightclub with type thing. I mean, come to class. You don't have to be in a Fortis shirt, but be professional. And when you talk to me, you realize I've got 100 students. I'm trying the best to do whatever I can do for you. All courses start Monday at 12 a.m. So for instance, next week, quiz 2 opens Monday night at 12 a.m. But don't you do that quiz till you come to class. I will go over it in my PowerPoints, or it's going to be in the Kahoots. So come to class first, and then you can do PowerPoints, okay?
Did you say quiz 2?
I mean, quiz 1.
Okay.
Is due on week 2. Boy, I
Okay.
got those numbers cracked up. Okay, week 2 has quiz 1. So It is up and it's ready for you to open and to use. Now, I do follow late policy very, very closely. Again, if you have something that is due, you can't get it done because you had to run your kid to the hospital or you're not feeling well or whatever, tell me before it's due and I will grace you that 10% deduction, okay? So that's very important to understand. Again, communication. Now, after 1 week, I haven't heard from you, it will be a 10% deduction and it can be due up to 1 week later. So it's only 2 weeks it can be turned in. After 2 weeks, you will get a 0. That second week, if you haven't told me, it'll be minus 10%. So if you don't hand in some of these big assignments, it will negatively affect your grades. I've had students fail because they didn't turn in the big project at the end of the class. And I'm telling you, I will send you messages. I will send you little notes. Hey, you didn't do the discussion question. Hey, that case study is due. Or here is your assignment. If you change this, this, and that, I'll get you a better grade. I communicate with you to try to help you. And when I send announcements, I don't send many. If I send them, pay attention to them. I'm not one that will send you 18 announcements in 1 week. No, maybe 2. 3 is a big week for me, okay? So one of the things that's misunderstood in online is how we do attendance. It's not just coming to Zoom class, okay? It is you putting in your modules, your attendance attestation. That's 1 point of contact in the Canvas. This week, your second point is your NCLEX questions. Every week, there must be 2 points of contact. That's why I say, if you want to do the NCLEX studies or the Kaplan early or discussion boards, save them, don't enter them till the week that they're due, because you want to make sure you have points of contact in Canvas. I have seen students just taken out of the course because they didn't have any points of contact. And this one student that I'm thinking about would send his work in by emails, not through Canvas the way it should. So it can happen. I've seen it happen. Again, you don't sign it, you didn't do it. I will send you reminders, okay? So just make sure you do what you need to do. Make sure you get it in on time as much as you can. Make sure that you have some method of keeping track of when assignments are due. Every class, I will tell you what's going on, what is due, what to look for. I mean, this week we have a discussion question and you need those 2 peer reviews by Sunday. This week, I don't take off for late. I don't take off. Many class changes have occurred. So this week I'm a little lenient, but it must be APA, and I'll be showing you. I'll send you messages. So make sure you look at the messages. I follow the syllabus, and that is your Bible. That's the way it should be. I do look at the Zoom and make sure that you're here, okay? It's for me to say, okay, you can assign the attendance at the station. If you weren't in class and you sign it, I'm gonna say, did you look at that review video that I send out? And how do you know that? Well, I'll give you 2 or 3 questions for you to do to tell me that you've seen it. Now, what if you were didn't come to class and you did just the video? I'll send you 2 or 3 questions. Those questions will be some concepts that you're going to see on exams or you're going to see on your HESI. They're going to be important. So it's not going to just be a waste in time. Now, I don't do per se review sessions, but I am always open, available to help you understand things. If we get to the point of cardiac and you don't understand it, reach out, I'll sit with you. I can do that. After the exam, you didn't get the score you'd like, I will sit with you. I'll do one-on-ones, or you and 2 of your friends, whatever. I'm here to do everything for you to understand. This is that semester where you're going to start taking information and applying it and understanding it more. It's like bells are going off. I remember when it happened to me. Your KGA is your quizzes, your exams, and your HESI. HESI equals 78. After that, we add subjective. Make sure you get your best subjective grades you can, because it can negatively affect. When you're doing the quiz, let's say all of a sudden there's a thunderstorm, your electric goes out, or the internet's cut off, or something, and your computer dies. Tell me immediately, send me messages immediately. I can see times when you answered things. I can see what you do. We have had little fingers like the bottom have gone and done the rest of quizzes for their mommies and daddies. So make sure when you do your quizzes to sit down and to do them all at one time. They are timed and it's 15 minutes. If you have any sort of accommodations, I need to know so I can put in for next week your quiz, given your extra time, and set up what we need to do for your exams. We know exams are exam soft. If you want to do them on campus, let me know, send me a message, and then I need to get verification with whoever's going to proctor on the campus. If you're going to miss an exam or you can't do it that day, notify me before. If I don't hear, you don't show up, you're going to get a 10% deduction. You don't want that, okay? So as soon as you know you can't get to the exam, let me know. I'll work with you. I do have other classes. I can proctor you separately. Let me know. When an exam is missed, you have 1 week to complete it, unless it's an extenuating circumstance. All right, homeworks, again, make sure you write them down, you know what's due, check them off, cross them off, do what you need. Know that on the second week, it will be minus 10% unless you let me know. NCLEX questions must be submitted in the proper format. You can do them until you get the grade you want, okay? I have multiple submissions on your Canvas to let you know. Again, if you don't know how to do this, I do have an information sheet I can send you on the instructions. Remember, every NCLEX question is 1.25% of your grade. So actually, they can fail you if you're that close, okay? So make sure you do the best you can. Case studies, I do not have open. NCLEX questions are, your Kaplans are open, discussion questions are, but your case studies, I want them open when I have them set. I want you to do the material that we're studying in class those weeks, okay? It's the only one I won't change. Trying to go through this quick. Now, APA format paper. You will see on week 8, you have a clinical pediatric assessment. You are to pick a pediatric diagnosis, clear it through me so I could say, yeah, I like that one. And you're going to do 3 components: a 250-word APA paper with references. There is a handout on assessment, what assessment I want you to look at. Don't tell me the cardiovascular is within normal limits. What is that? Is there regular heart rate? Is there a murmur? Please tell me what it sounds like. I don't want a WNL. I don't within normal limits, okay? Describe it to me. If you're giving me a paper about asthma, tell me what the lungs sound with asthma. Simple. And I say, choose something that's near and dear to you, whether you have it, your children, your next door neighbor, your mother, your father, your aunt, your sister, the kids, your cousins, somebody close to you. Make up a virtual child or somebody you know, okay? There is a rubric in there and it's APA. Good thing about this project, if you turn it in early, I see some places where you could improve. I'll send it back, tell you what to improve. If you improve it, you still can get 100, okay? So if you send it back, send it back. You want a good grade, I will give you the good grade if you do what you're supposed to do. Again, quizzes is once. Any problems, immediately let me know. And this is also with exams. Let's say you're having big thunderstorms. This happens in North Florida a lot. Thunderstorms and the internet goes out. Let me know beforehand you're having the storm. And if we're having it, your computer goes out, stop immediately, send me a message, and I can always restart your exam at another time. We can make another plan. Kaplan, do not send it to me. I do not want screenshots. I have to go in and look at it, okay? Just remember, you must remediate every question. If you got 100 that you earned, no remediation, you'll get a 50. But why? Why do I do that? Well, you got it right, maybe you knew it, or maybe you sort of knew it, or maybe you guessed. This is a way to re-emphasize those things that you've answered to show that you really know why that question is that answer, okay?
Do we get only one shot at the Kaplans
you
as
can
well?
do them 18 times if you want.
Okay.
But the one that you get the 100 on, or your highest grade, that one must be remediated, okay? I don't care if I see 4 times. That's just showing me that you're trying really hard to get your best grade. As these are a week 11, we'll do it. You only get 1 attempt. There is remediation. I've got some great information for you to do the HESI. Most of my HESI scores are above 900, but do what I tell you to do. And as we get closer to that, it is 2 Kahoots I have, a PowerPoint, and you always have your NCLEX book for pediatrics. I highly suggest to look at that as we go through the semester. It's got some really good information and in a way that maybe you can understand it. And then you can come to class and say, hey, I don't get it. Could you explain it to me? And I will. What else? That's it. So that is just the the PowerPoint Dean came out with. I wanted to highlight what's important for me. So any questions yet? Everybody's good?
I have a question on the NCLEX. I haven't really had a chance to look at the syllabus in detail and the modules. Are we doing certain subjects each week in NCLEX or yeah?
Yes, okay. You are. Be careful. The first week is growth and development.
Okay.
It's not pediatrics. It's under growth and development. It's a separate topic. Okay. Thank you for mentioning that. I almost forgot. Anybody else? Patrice, are you there? I'd like to say hello. Ms. Brooks? There you are. I'd like to say hello.
Sorry, my 3-year-old.
I love those 3-year-olds. They're the best. Okay, let's go and do our first PowerPoint. You have all of these PowerPoints. I do send the PowerPoint and I send it with the announcements for the weeks so that you have them all in one place. If I need to send more than one handout, like I did with Erickson and with Vital Signs, I'll send them as messages because PowerPoints can only be with the announcement because it's one thing I can attach, okay? All right, taking care of children. So, today we used to just treat symptoms and what happened to children, but with adults, children, we're taking care of kids to prevent illnesses. So in Healthy People 2020, what they look at in pediatrics is their growth, development, are they up to stage? But what affects that? And that is nutrition, nutrition, nutrition. If a child as an infant isn't getting proper nutrition, they're not going to grow properly. Their muscles, their brains are not getting what they need to be healthy. And so nutrition is important. And then oral health. If your teeth are rotten, they hurt, right? How are they going to eat properly? So these are 3 things set down by the government. Other healthcare problems are obesity, type 2 diabetes. We have young children today that are more sedentary. They're in computer games, they're not up, they're not outside. And we know we have mom and dad working and coming home and there's a lot of fast food because there's no time. How can you cook the way you're supposed to? Children today, years ago we had mom at home and they would fix dinner and it would be better dinners. It's not happening today. Child injuries, it's called unintentional injuries. I mean, think about toddlers jumping off the back of a couch onto the hassock, missing it on the floor, and their heads hit, these solid tile floors. It can cause injuries, and that's part of it because there's really no filter. Kids have no filter. They don't think about getting hurt. As they get older, it's more violence and school bullying. And you think that mental health problems are only for adults. I've seen children with severe mental health illnesses. One little boy, I remember clearly working. My last job that I did was 10 years at Nicholas Children's Hospital in Miami, Florida. And I worked in the emergency room and I was a trauma nurse. And one of the things that I saw is this little 6-year-old boy with schizophrenia and how he suffered with it. And as he needed like updating in doses, I would see him come in having issues. So mental health is really a serious issue in children. It can occur. I mean, these pictures are clear. Guns, kids get into them. I mean, adolescents try to think they're cool and have guns and, gangs and all that whatnot. I mean, think about swimming. I live in South Florida. I mean, I've told you the earlier students who came, I've got a grandson, I've got a pool in the backyard. Now by age 2, the kid could do front flips in the swimming pool. I taught him how to swim because I'm a water rat. I think he swims better than me now at age 5.5, 5 3/4, excuse me. But, swimming is a big deal in drowning. And I've seen many children with drowning with positive and negative outcomes. We know plastic bags, the stove and pulling them off. I've got an older brother whose arm has scars till today of oil being pulled on his arm. And we know they like medicines, they get into it. Probably the most of all of them is vitamins. They think they taste good, so they just start chewing on them. As long as it's not Tylenol, which can affect the liver, actually vitamins aren't too bad. Some of the highest risk problems with health problems are those that are small. They're premature, the very low birth weight, and the low birth weight children. They're in the hospital a long time. They have a body defenses that aren't mature at all. So they have some big problems as they get older. Children in daycare. I call it children who go to daycare, they swap spit every day, right? They play with toys. It goes from one kid to the next kid, to the next kid. So these germs go round and round and round. So it causes health problems, right? Living in poverty, homeless. There's many families one paycheck away from being homeless. you know, and I live in South Florida, and there are a lot of immigrants because there is a lot of, you know, vegetables and whatnot to be picked, etc. And immigrant families do have some big health problems. And what I have seen and with my own eyes is immigrant families don't like to go into an emergency room. And when they finally get their child there, that kid is sick. And the reason is they're afraid I'm going to deport them. You know, we know we're not. That's not what nurses do, but this is what they think. So they wait. Those children with chronic medical psychiatric illnesses, this is a big thing, as I said. And then there's barriers. And a lot of the barriers is, I don't have $5 for the deductible. I don't have a car to get there. I don't have gas to get there. I have to work. I can't bring them. So there's so many barriers. I could go on and on. Infant mortality, infants, this is up to 1 year old that they die. We know the first 28 days are the most critical, but they can die up to 1 year old. And many countries are really good with low infant mortality rates. The United States not. We have a lot of infant mortality. We have a lot more to do. I mean, working since 1984 in the pediatric place, I have seen so many changes just in the newborn ICU, the way that we touch them, the way, et cetera, et cetera. It's a lot, but we have a lot more to do. And we know infant mortality, one of the big things is how big were they when they were born? The smallest I've ever seen is 480 grams. That's 11 ounces. That's less than 1 pound. After 3 months, the child died. He tried so hard. As we get older, the mortality is less, school age less, but then go to adolescence. Now, they get a little bit braver. They are with driver's licenses now. They're getting into their groups, their gangs, and the homicide, the injuries. And then they're really adolescents. Their biggest thing is body image. And a lot of them suffer from depression. So suicide is a big one for adolescents. So let's talk about family and culture. Pediatrics is a family-centered care. Many nurses don't go into pediatrics because there's a mom and dad with the child, and they don't want to deal with that mom and dad. It's very difficult sometimes. I know that if there was a difficult family, that was mine, because somehow I knew to deal with them. And what did I do? Well, I empowered them by having them help me, have them to look out for stuff, to teach them, and to tell them that I appreciated their help. So now they felt good. They don't feel helpless. So the one thing about family, I mean, through your whole life, it is that one constant, isn't it? Family's that one constant in their life. And what is a family? Well, it's whatever you say it is. I mean, my grandson initially, what is his family? It was Pop, Nana, and Mommy, and him. That was the family. Today, his family is him, his mommy, and his new daddy. You know, these are families. Families could be all different things. Could be nuclear, blended, extended, single parent, LBGT, it doesn't matter. Family is whatever they say it is. So culture, you're thinking culture, culturally competent care, right? All right. One of the things that I had a hard time when I first moved to Miami was I was from a very small town, and there was just, you know, Americans that lived there. There wasn't all the cultures, the Hispanic, you know, it was a change. So I had to learn. I had to learn different cultures and how to respect it. We know that there's ways that you can treat your illnesses, whether through different herbs and teas, and it's all about praying and prayers and rituals. All of these things are part of your child that you're taking care of. So opening your mind, not to understand, but to have these children be able to practice what they believe and the parents believe is going to help them. So let me tell you what I hit when I came to Miami. I'm from this very sheltered little town. So tiny little town. There was 2 stop signs in it, okay? That's how small it was. Many times you will see parents say, my kid is with a cough and a cold and a fever because they were outside in the rain and they got wet. Or they went to bed with their hair wet. They didn't dry it before they got there. Does that cause illness? Well, to them it did. So, okay, that's one. Another thing is in Miami, there's a lot of Hispanic. Now, grandmas believe that if you are in the house with tile, you must wear socks because the tile floor is cold. And if you don't wear them, the cold is going to make you sick. So, all right, let me give you a scenario. You get this little child, let's say a 2-year-old comes in, has a fever, and your goal is to keep that fever down because when it's down, they're active, they eat, they drink, and they're okay. When the fever goes up, they look sick, they don't eat, they don't drink. So having them with bare feet on the floor does what? It makes the cold, right? The cold comes into the body and it helps decrease their temperatures, just like hot and cold beverages. Cold beverages on a child with a fever does what? It brings down it. So, and then there's the voodoo and witchcraft, but all of these things are their health beliefs. My husband is Jamaican. He believes that there's ginger tea and then there's garlic and all of these different types of teas. And that's what's going to take care of his illness. But I say, as long as you are taking your other medicines, we're good. Excuse me in my voice. I'll tell you why later. So religious beliefs. Now, many times I worked in the cardiac intensive care unit for 10 years. My favorite of all my units that I ever worked in. I was very blessed to open this unit at the hospital. And one of the things is these children come in very ill. They come in where we don't know if they're going to make it, and some do and some don't. Many parents want to do a baptism. So I would always offer, do you need a rabbi, a priest, a minister, or whoever to come in? And, you know, giving them that opportunity to do that baptism on that child without causing harm, of course. What about that child who needs blood? You know, infants, newborn infants do not make their own red blood cells yet. It's like about 3 months old, they start making red blood cells. And if you are that infant in newborn ICU or cardiac ICU, you're going to be taking blood. You need to look at things, you know, like white blood cells and electrolytes. So they're not replacing that blood. So all of a sudden, their hemoglobin and hematocrit are 6 and 18, and they're symptomatic. And symptomatic would be apneas and bradycardias. Now you look and your infant is Jehovah's Witness. They do not believe in blood. So what do? Well, we can get a court order to give that blood product to that child because we're looking out for the child's safety. But these parents do not need to see this blood bag and this tubing so that it's in their face. I've done it on day shift and night shift. When I did it on night shift, I would let the parents go home. Let them go home and then I'll say, call me at midnight, I should be done. The day shift, I would have the parents step out and I would do what I needed to do, hook up the blood, I would cover it with blankets, and I wouldn't leave the bag out or anything with blood so the parents didn't see it. So I am respecting their religious or cultural beliefs. And I've had parents 15 years later come to me and thank me. So it does make a difference. I mean, just because you have to do it doesn't mean these parents need to be, seeing all of this stuff. So there's all different things we can do to help these parents get through it.
So for NCLEX purposes, when we're taking an NCLEX and they ask a question like that based on religion, are we to
respect wishes?
Okay.
You're going to respect wishes as long as it doesn't compromise the child's care.
Okay. Gotcha.
It's all about the child, number one.
Thank
then
you.
Respect their wishes. That's a
Thank
great
you.
question. So, role of the pediatric nurse. You are going to be their psychiatrist between mother, father, grandma, grandpa. It can be quite intense. But the bottom line is they're all concerned about the child. So teaching them, letting them understand how to take care of their children. I would teach them little things to help me. My job was actually easy because my parents and grandparents helped me take care of the child. They were my eyes, my ears, and I could see when I had to go back quickly into the room to take care of that child. So our role is we're that person between the child, the parents, and the doctor. And I'm telling you, nurses make a big difference in pediatrics. Again, it's that support, that counseling. Nursing process doesn't matter, adults, children, it's all the same. So question, we have a leading cause of death among African-American boys ages 15 to 19 is. Remember I tell you as they get older, they get a little bit more, brazen, and they, will go get that gun and look at it. Mm-hmm. And literally the age 15 to 19-year-old boys is firearm homicide. They want to pick it up, they want to look at it, and that's when those guns go off and things happen. Okay, here we go. We're going to talk about growth and development. If you think about what an infant is at birth and what they are doing at 1 year old, it's amazing. They're born at 7 pounds. They triple their birth weight by age 1. And they go from not being able to lift up their head to at least standing up and taking several steps. That is amazing. It's interrelated, simultaneous, ongoing, and if you blink your eyes, it's going to be done. There's different ways to describe the growth and development in children. This is part of your readings also. It's directional trends, sequential trends, developmental pace, and I have some NCLEX questions on these also, not NCLEX, Kahoot questions that you can look at, and we'll discuss them more. I mean, sequential is probably the most important of all of them. It's basically, you lift your head first, and then you start rolling, and then you creep, you crawl, you walk. It does not mean you can't go from getting on your knees and then getting up and walking or running, as long as they're going in that sequential trend. You can always miss a step in there. My kids, my 2 children that are older now, and this grandson, Christian, that I've talked about, they never walked. At 15 months, they all ran. They ran away from me. So this is what I'm saying about sequential and being able to skip. As they get older, so many changes going on. Their metabolism. I sent you a vital sign sheet. Normal heart rate for an infant, 140 to 160. An adult, 60 to 100, right? Big difference. So it gets lower and lower and lower as they get older. When they're born, they can't hold their body temperature. That's why we have to make sure that we keep them warm or underneath a warmer. Sleep, infants sleep a lot. They rest a lot. And in any age group, I mean, literally up to adults, and elderly, nutrition, 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 especially when you have kids that are growing. You want to feed their body, mind, and soul. This helps them get smarter, get stronger, get taller. How do we measure that? Well, Don't we do height and weight on every visit? Yes. Height and weight measures many things, and it does measure if they're getting proper nutrition. And temperament and significance is going to be talking about a theorist. If all needs are met, these children are going to be the happiest kids around. It's when a kid cries and cries and nobody gets them to feed them or change their diaper or whatever they want. So there are theorists, and I've sent you a handout on it. The most of all of these that you'll see, Erikson, Piaget, Kohlberg. And I do have some great Kahoot questions that do describe them. And next week, as we go over infant, toddler, preschooler, I'm going to tell you and show you simplistically enough, I hope, what these theorists mean. They say all these big words like Erikson, trust versus mistrust is an infant. Well, what does that mean? Well, the trust is when I cry, somebody's going to come get me. I'm going to be fed. My diaper is going to be changed. I'm going to be held and I'm going to be burped. Mistrust, nobody comes. And I cry and I cry and I cry. That is one of the things we'll talk about. Now, one of the things I did every day when I went to work is I played. Every day I went to work, I got to play. And that is the best thing ever. Children, what do? For the first how many years of life? They play. And this is how they learn and how they become logical and understand things. Now, first of all, it starts with sensoromotor development. Sense is the touch. What does it feel like? Is it hard? Is it soft? Is it coarse? Is it smooth? These are things kids look at. Oral, in the mouth. Kids explore the world through their mouth. Freud says that. All through their mouth. I mean, look at kids 5 years old, still everything in their mouth. Get it out of your mouth. Get that pencil out of your mouth. Get that toy out of your mouth. Everything in the mouth. And then motor. Little babies even taking a rattle now and moving it and listening to the sound. Sensoromotor development. This is very important. It develops their intellect. So now they start knowing that if they see that rattle, they can grab it, pick it up, and they can make a noise. That's a big thing for an infant. They've just learned. And this is talking a lot about Piaget, but we'll talk about that next week too. They socialize as they get bigger. They're creative. I mean, look at that kid. How creative is purple everywhere? And that sense pleasure is what they have type of play. They've got the smush everywhere and they're happy. So there's types of play. You need to know types of play. So the one that's a big thing is sense pleasure. That was the touch, the feel, that's finger painting, that's sand and mud and water and all that gooey stuff. This is actually something they enjoy doing. Because again, sensoromotor, hopefully they don't put it in their mouth, especially sand. And then dramatic is something we use in the hospital. We want to sometimes know what happened to the kid. So we'll put them with dolls or toys and we'll see what they do to those. It could be a sexual thing that happened or an abuse thing. We can tell by this dramatic play. Now, all of these different plays, onlooker, they're looking at somebody else play. That's it. Solitaire, I'm playing alone. Parallel, you're playing next to each other, but you don't have to play the same things. You're both playing in the same area. Associative play, you're playing together, but there's no rules. There's not an outcome like checkers would be cooperative play. Cooperative, you do something together and there is a goal in the end to win, okay? Very important that you know those. Again, you're gonna see them in Kahoots. So toys does so much. It helps with their development. It helps actually bringing parents and other adults and children, brings them together. It's that moment, you know, children, even young little infants, you can have them put their tongues out and stick it and wiggle it, you know, and they can make noises like you. It's actually a great moment. I like to do it to kids. Also, you see toys, the kids are reaching for it. So it's good for that movement and muscles and coordination. So toys are good. Now, when we get an infant child into the doctor's office, even into the urgent care and ERs, we're going to be doing some sort of developmental assessment to see, are they on where they need to be? Now, why do we do this? Well, many children are behind. They don't, maybe it's their speech, maybe it's their physical activity, maybe it's a child that by age 6 months can't roll over. And we know they should be able to roll over front to back and back to front. They can't. So what do we need to do? Well, we'll have some early intervention, and we could put in physical therapy, occupational therapy, and that child with speech therapy. Kids are so resilient. They're going to catch up so quickly. And why not get them caught up quickly instead of waiting until school, right? Children can be born with all sorts of abnormalities, whether it's club feet, whether it's cleft lips. It could be due to many different reasons. Could be some genetics that's going on, could be chemicals, alcohol, could be drugs, all things. So there are things that can cause children to have some issues, at birth. So what is your goal as a nurse with all of this growth and development and all of that? Well, number one, we need to provide education for the parents. They need to know safety. They need to know what they should do, how they can help assist it, tummy time, back to sleep, all of these things that we do as a nurse. One of the things that I have found is that parents actually do feel guilty. When I worked in the cardiac ICU, I'd have mothers with children with, severe cardiac defects on their newborns, feeling like it was that glass of wine or that Tylenol they took. And the first thing I'll say is, you had nothing to do with this. This has to do with the way your child developed, intrauteral. So don't think it was anything you did, because moms, and especially their post-delivery, they're hormonal. So to help them really does make a difference. I've had children like with cleft lip, cleft palate, and it sort of doesn't look good. The first thing I'll do is I'll have the mother or the father sit down, I'll roll the kid up in a blanket and hand it to them. And I'll go, oh my goodness, look how much hair that kid has. Oh, wow, look at the color. I'll look at those cute cheeks. I'll do something to help them to bond with the child. And if they need some sort of therapy, I want to tell the doctor. Nurses at this point are so close and spend more time, they know better. Now, a father tells a nurse that his child is filling up the household with collections, such as seashells, bottle caps, baseball cards, pennies. The nurse should recognize, what is the child doing? Well, all of these different things we're going to talk about more, but let's go into it briefly. Object permanence is not the answer, but what object permanence means is a child sees something, they remember it, even if they don't see it in sight. So if you have an infant, there's a rattle, and you put it behind a stuffed toy, that kid's going to go looking for it because they still know it's there. The 1-year-old, you put the truck back in toy box. He knows it's in toy box. He's going to go get it. Object permanence. Then there's pre-operational concrete. These are things with Piaget. I just redid week 2 PowerPoints, and I made sure this is covered beautifully next week, but just to let you know, it's going to be there. So history, physical, and doing assessments. Now, there's always HIPAA, even with children. The one thing with children, you have pediatric, it's up to age 21. 18, 19, 20, and 21 are adults. They're cognitively aware. Mom and dad cannot get information unless that child approves of it. These children will sign their own consents. Okay, that's the one thing we have to be really aware of, that we don't give out information without proper permission. talking with families, working in an emergency room, for the last 10 years of my career, talk with many, many, many different parents. Let them talk, but keep bringing them back to why are you here now? Because they're going to tell you since birth. And if it's an 8-year-old child, it's a long story. You don't have 2 hours to listen to all of it. You want to know what's going on now. Always sit there and listen, and then being empathetic. This is probably something I took really seriously. Get a little infant, 4 months old, comes in, had a fever for 4 days. She's already been to the doctor. She's already been to urgent care. Now she's, here with me with her infant. The first thing I'm going to say is, you must be exhausted. You've been to all these places. You're really doing a great job for your child. Let me see what I can do for you. You've identified and you've told them you understand they've really tried really hard. And something that's going to make them feel better because they're exhausted. Always let them talk. Try to avoid any robots. And if you have a parent that doesn't speak your language, a 16-year-old son cannot be the interpreter because they're going to put their own impression upon what they're saying. Go through interpreter or go through that blue phone that they have. Talking with children. Well, number one, you're not going to go right in and touch that kid. That kid is scared of you. Many child has ran out the door, down the hall, and out the exit as I'm yelling, security, get that kid. I'm serious. Children are afraid of the medical profession because we're going to give them that shot, right? So first thing you walk in, you're going to break the ice by doing nothing first. Then you're going to get on their developmental level. Like, wow, you got a Batman shirt on. That's cool. My grandson has one too. I said, wow, and those sneakers. Do you run fast? Now, what have I done? I'm not threatening anymore at all. Then I can let them play with the equipment, have them help me do things. And I just spend a couple of minutes doing that. And I'm going to get what I need. And the child's going to get the assessment that they need. Always use play. Always get on their level. When you are getting information and there is a group of people with them, and in Miami, especially Hispanic culture, there could be 6 people bringing a kid to the emergency room. Find out, who am I talking to? Who is with a kid who knows the information? Because it may not be mom. It might be grandma, or it might be the aunt or friend, whoever. So make sure you know who. What's going on this time, and then start looking for what symptoms are going on. To follow, of course, you need to know, were they premature? What sort of delivery? Any illnesses before? Always allergies you need to know. And if they've had any medicines, Tylenol and Motrin are important if they're there with a fever. And if a kid comes in, 2-year-old kid, fever, coughing, respiratory problems, I want to know if they've had immunizations and if they're up to date. It could be pertussis, which can be very dangerous. To me, I'm immunosuppressed. It could be really dangerous. So immunization is very important. And then I'm going to look, are they up to date, growth development? And then if they're being admitted, I want to know a habit. My grandson needed his blankie and his little giraffe stuffy toy. Or you could not do anything with him. Would not go to bed, would not take a nap. You couldn't calm him down. So I want to know habits. Do they suck the thumb? I'm not going to put an IV in that hand. So those habits are important. Sexual history is mostly your adolescence. Now, the one thing I've learned with adolescents, again, you need to break a little ice with them. Say, so are you going to college? Are you doing school? Do you play sports or something? Break open some ice. Always, any sort of child. But if I'm going to talk about a sexual history, I'm going to ask the parents to leave. Most adolescents aren't going to tell you in front of their parents. They don't, I mean, my mom, there's no way I'd say anything. Not even if I kissed a guy, no way, because I'd be punished for my life. I had 6 brothers. I'm gonna be punished for life. With these children, you know, let them talk to me, explain what was going on. For instance, child's in with the second UTI in 4 months. I'm gonna close the door and I'm gonna say, why do you think you have urinary tract infections? And then ask, are you sexually active? And then I could teach this adolescent. It has been said if you urinate right after sex, it helps decrease urinary tract infections, or take a shower, wash your hands, clean, whatever, so I can help her. Now, do I have to tell the mother? No, unless this information is harmful to themselves or others, okay? So this is one way that you get information from an adolescent, probably the hardest of all the children's. You know, knowing how they're doing in school. I always say, how you doing in school? Parent-child relationships. I mean, I can usually tell by walking into a room, and, you know, our ER had closed doors, so the door would be closed. I walk in, the kid's on the stretcher, they have the otoscope out, all the little black ear things everywhere, drawers are open, alcohols are thrown around, and the mother's there texting on the phone, and that parent-child relationship, she has no control of that child. And she brought her child to an emergency room. So it really, really tells a lot. I mean, you need to know what's going on with the body. Of course, nutrition, right? I want to know what their dietary intake is. A toddler are very, very picky. Many toddlers, it's macaroni and cheese and chicken nuggets and apple juice. They don't want nothing else. Now, is that nutritionally appropriate? Well, I'd get it evaluated, but maybe they need to add a vitamin. I mean, these are things we can evaluate. We're going to look at height and weight. Again, that measures nutrition, that they're growing properly, temperatures, etc. And you'll always prepare that child by doing nothing at first, then getting on their level, and then, you know, having them participate in it. You need to know normal vital signs on a child before going into their room. You know, as I said, infants 140 to 160. It doesn't mean that they're dehydrated or have a fever or they're in pain. That's their normal. But what if that was a 1-year-old? That would be elevated. So we need to know those sort of things. Looking at everything, touching their bellies, I start to tickle them, make them have fun with it. Looking at reflexes, you know, are they, you know, when you touch them, are they trying to get to you so they can drink something, or is it a startle reflex? Now, one of the things, as I said, we do height and weight before any visit, whether doctors or any sort of urgent ER care. That little wood thing coming down that goes on top of this little girl's head, most kids won't get under it. They're afraid it's going to bop them on the head, it's going to hurt them, so they don't want to. So guess what I do? I'll put it up high, turn around, put it down. I said, oh, let me just touch my head. I said, look, I'm a number 7. Let's see what you are. And the kid gets up, turn around. I said, you hold it. You tell me when you feel your head touched. Oh, look at your number. And we make it a game. Games are fun. Blood pressure cuffs. You know, the little premature infants are 0 blood pressure cuffs. It goes from that up to extra large for adults. You know, 4, 5, 6. These are all numbers of cuffs. You need to know what you have to choose. On toddlers and on preschoolers, I'm going to do that blood pressure on the lower leg. It's least threatening. I can hold that leg. I can distract them with maybe a stickers or talking about something else, get the blood pressure done, and it don't hurt. On the arm, they hurt. It hurts me. It hurts the kids. Again, looking at general appearance, you know, seeing if all the normal stuff. And then pain, our last chapter tonight. Pain management in children used to be non-existent. We didn't think kids had pain, and premature children, their nerves weren't, good enough to feel pain. Well, we found out we were wrong. Yes, they do have pain. So we need to treat it before it's too much, just like adults. We need to give the medicine when it's due, not waiting too long. And we need to be able to evaluate that. Adults, children, chronic, reoccurrent, persistent pain could be due to they had surgery, an appendectomy, could be a cast on an arm, could be ear infections, I think are the worst. They really hurt kids, ear infections. And then we need to evaluate 0 to 10. 0 is no pain, 10 is the worst pain in the world. A 1-year-old can't answer that, but we have tools to use. Now, this one on the bottom is called Wong-Baker's FACES scale. This one is good. It cannot be used till they're a preschooler, according to your book. So 3 years old is when this can be started. And they literally will look at it and say, I'm number 6, and they'll point to the face. They do use it really well. Now, infants and nonverbal children, the last one here, the FLACC, F-L-A-C-C, pain assessment tool. It measures what the kid looks like. Their face, are they grimacing? Their legs, and kids in pain, their legs are gonna be moving. An activity, they're gonna be wiggling. They hurt, and they're gonna be crying, and you're not gonna be able to console them. And it works really well. Nonverbal children, I've had 18-year-old nonverbal cerebral palsy children. I use that on. And I also use that on infants 1 and 2 years old. There are different ways that we can look at it. There are checklists, but FLACC really works well. And remember, cultural differences. I've seen, remember, I live in an area with a lot of Hispanic families. To let you know, my children are half Cuban. And actually, my last name is Bogart Diaz. So I understand the Hispanic thing. I have seen fathers tell their little sons, you're not in pain, you don't need any medicine. And this is with a bad earache. Or they need to get a cast on and I want to give morphine. Oh, you don't need it. You can deal with that. Suck it up, kid. You got this. And I'm like, this really hurts. We need to give them something. So cultural differences can make a difference here. Now, beside just pain, there's other stuff that can be done, just not medicine. We can give Tylenol, we can give ibuprofen, we can give morphine, we give milligrams per kilogram. We know what dose can be given effectively, efficiently, and safely. But there's other stuff. How about if we give them an iPad, let them play, or we blow bubbles for young kids, or maybe I like music, turn music on, kids' pains go away. Give them a coloring book, give them stickers, distract them, and they're not feeling about this pain. There's different ways of pain management, and this little girl here is smiling. That little Tegaderm with that little white blob there, that is a numbing cream. And what it does, it makes that area numb. She's just about to have lab work, but she knows it's not gonna hurt because she has numbing cream there, because we try a traumatic care for children. We know children have teething, immunizations hurt. That's why we say give some Tylenol for that, or some warm or cool packs on the thighs as we give them. It could be due to surgeries and tonsils, could be sickle cells. Children have real pain and they must be treated, and we need to treat it before it's too far gone, just like adults, right? Any questions? So you want to play a Kahoots. Have you played a Kahoots before? On your phone, you are going to go to kahoot.it. And your number is 830-5791. I believe there's 35. We will be getting out a little bit early tonight. Yay. I will have your recording and the Kahoots. And again, on your announcement, I always reattach your PowerPoint. It'll be on by tomorrow, early afternoon. I have a YouTube channel, Professor Bogart Pediatric Nursing. Every recording I've ever done is there, okay? So you always can listen. Good job. They just changed to the Halloween cover. I love it. I love Halloween. Week 1. It's going to go by quick, guys. From a worldwide perspective, infant mortality in the United States, is it big? Is it little? Is it better? Is it not as good? What is it? And infant mortality is the first year of life. We have higher mortality than many other nations. I mean, I think of Switzerland and Norway. Those two always come up as some of the lower rates. Good job. The leading cause of death from unintentional injuries in children is what? Unintentional means nobody did it, it just happened. And in children, I mean any age. And it's motor vehicle. You're going to see that in any age, whether they're in the car or underneath, rolled over the car. You know, working in an emergency room in the trauma center, I've seen about 4 children ran over, one by the next door neighbor, one the mother, and one an aunt. And some kids, no injuries, and other kids, massive internal. So motor vehicle is a big thing. That's why we have backup cameras now. It's part of it. Which statement is most descriptive of a pediatric family-centered care? Family is the only constant in their life, you know, and we know pediatrics is not just taking care of a kid, you take care of a family, you know, and it is difficult, but I've made family friends for life being a pediatric nurse. The major cause of death for children older than 1 year old is what? And we call it unintentional injuries. It's injuries that just happen. We can't predict all of them, you know, and these kids, they have a mind of their own. The nurse caring for the child in pain understands that distraction. My dissertation was on school-age children attitude and behavior towards injection. And part of it was that we can decrease in the stress and the pain of injections by one of the things is distraction. But when we're using distraction, it must be that the kid understands it, right? Developmentally appropriate. You can get that kid from thinking about that pain. It works great. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? There's no goal. That means there's no winner. They're just playing together, doing the same thing. That is called associative, okay? Cooperative is when there is a goal, somebody wins, like checkers, a board game. It's a very good example. Which statement best describes the process of critical thinking? You know, when you all started nursing school, one of the first days they tell you that you have to learn how to think critically. And you're like, when am I going to know this? Well, if you need to have something for dinner, you look at your cupboards, see what you have, go to the grocery store, get what you don't have, go home, and then you make it. That is critical thinking, as simple as that. And in nursing is understanding a piece of information and how to use it in the big picture also. Good job. What is probably the single most important influence on growth at all stages of development? I don't care if you are a senior or an infant. Nutrition, nutrition, nutrition. If you don't eat right, you're not growing right, your body's not getting what it needs. And we measure this a lot through height and weight through every visit. Frequent developmental assessments are important for which reason? Why do you want to know if a kid can turn over or lift their head up or crawl or walk or jump on a foot or button something, or why? This is what we're going to learn next week, all of these developmental things that we need to understand. That's how we can do this developmental assessment. Stable development, if we don't get to a certain area, we know there's a problem. I'll give you another example. 7 months old, you take the kid on the back, take his hands, pick it up, and the head falls back. That's called head lag. Well, they should have head control, right? By 3 months old. If they don't, what's going on? There's a problem. Is it a neurological problem? What? We can institute physical occupational therapy, or we can find out what's going on in the brain. Is there a tumor? Is there hydrocephalus? What's happening? What function of play is a major component of play at all ages? What did I tell you about play? I mean, this one thing makes all the other stuff. So it starts with sensorimotor activity, right? The touch, the feel, the mouth, exploring it in the mouth. Motor, then it creates the creativity, socialization, and the intellectual development, okay? 3 children playing a board game would be an example of what type of play? You didn't know there were so many types of play, did you?
Oh no, hit the wrong one.
Gee, I hate when that happens. It's called cooperative play. Cooperative, and we're going to play checkers. So C, cooperative checkers. Get it? There's a goal. That's how I remember things. The head to tail direction of growth is referred to. This is just another word to understand. It means you start with lifting your head, and then you get down to your tail, your feet, and then you're walking head to tail. Remember, the word cephalic is your head, okay? So it is cephalocaudal, cephalocaudal. What is the single most important factor when communicating with children? You know, working in the emergency room, I had 4 kids. That was my assignment, and they'd be constantly switching, and you don't have much time with them. So I really had to be able to go in, do what I had to do to get to the next kid, right? So walk in on their level, giving them a sticker, or telling them about their shirt, or, you know, singing a song, whatever. And that really helped with the breaking of the ice. And then I was able to do actually whatever I needed. What 2-year-old child pain assessment tool should the nurse use? So at 2, what is the tool? And that is your FLAC. Phases start preschool, ages 3, okay? This is a type of question you're gonna see again, okay? I'm telling you, it's one of those that it's like, you think it's that, but no. FLAC up till preschool. At preschool, which is ages 3, 4, 5, the phases start. Up to age 8, 8 is numeric. At 6 months old, an infant's birth weight should do what? Now, many of these questions you're going to see again next week. I'm introducing you to those things that you're going to see. And if we know the answer to this, then if they're not at the proper weight, too much, too little, then we could do whatever intervention needs to be done. At 6 months, it doubles. At 1 year, it triples. The first expected fine motor developmental milestone for an infant begins with. Now, there's fine motor and gross motor. Think of fine, F, fingers. Gross motor, G, get up and go, 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 like Paw Patrol. Gross, that's movement. Fine motor is fingers. Remember that. There is a difference, and answers on exams and quizzes will be different according to what motor development I'm looking for. So first one is the child has a hand, you put your finger in it and he closes it as a reflex. Parents think, oh, look, my baby gave me a hug. It's a reflex, don't tell them. An 8-month-old infant should be expected to perform which fine motor skills? Fingers. And in your book, you're going to see it's going to be reflux, palmar grasp, voluntary palmar grasp, then crude pincer grasp, which will be fingers. Then it'll be fine pincer grasp. Then it's going to be making, putting blocks in a container, building a blocks of 2. This is the setup, first year of life, fine motor development. So about 8 months old, they should be able to get that rattle because they can hear it now, right? But then crude pincer, it might be like 3 fingers, you know, and Cheerios on a high chair going in the mouth, okay? Absolutely perfect, normal. The natural physical developmental sequence that most children follow is what? So this is actually gross motor, okay? This is movement. What's the first thing an infant does? And that will be your answer. So they lift their head up. That's the first thing they do. That's like tummy time. So they get their heads up. They don't get that square head in the back. Then they go from the front, roll over to the back. Then they go from their back, roll over to their front. Then they're up on their knees. They're calling backwards, forwards, getting up, cruising around the coffee table, and then walking. That's the way, the normal, natural sequence of events. Which behavior indicates that an infant has developed object permanence? What does that mean, object permanence? I told you. So object permanence is they saw the rattle. We know it's there, but you put it down and it's hidden. That infant will go look for it. It's actively searching for that hidden object. Or the 1-year-old, you took their fire truck, you put it in the toy box. He knows to go looking for it because it's still going to be there. In general, an infant should triple their birth weight at what months of age? At 1 year, 12 months, they should triple. Now, if you're born at 7 pounds and at 1 year you're 28 pounds and you should be 21, that means too much nutrition's going there. So you need to look at what nutrition's being delivered and we can make changes. Conversely, if it was 16 pounds, instead of 21, more calories. Something else needs to be given. And remember, this helps with cognitive and physical development. So nutrition, we need to get it right where it needs to be. Performing a head-to-toe assessment on a toddler, most important to consider before beginning this exam. Toddlers are ages 1 to 3. Preschoolers ages 3 to 5. And then their school age up to age 12. Again, preparing the examination based on that child's developmental age. And remember, you're not just going to walk in and start touching them. You're going to break the ice first. Then you're going to go on their developmental level and you're going to let them touch and feel whatever toys they want to feel. And this is your blood pressure cuff. This is your stethoscope. Let them touch and feel it. Let them take your temperature. Why not? According to Piaget, toddlers are in the blank developmental stage. Again, next week, you're going to get this one correct. This is going to be a hard one for you. Piaget is all about cognitive development, being able to see things, how they work, and then going beyond that and figuring out it has wheels. I saw them move. All right, this one can move, okay? It's called sensorimotor. Trust versus mistrust is Erickson. Autonomy versus shame and doubt are Erickson. Formal operations are the older kids with Piaget. You'll understand more next week. I'm just breaking you in this week. Which intervention helps a hospitalized toddler feel a sense of control? I mean, have you ever gone on vacation with a young child ages 1 to 3? It's pretty hard. They don't want to sleep. They don't want to nap. They get a little bit cranky. Why? And how could we actually change that? Following the usual routines, absolutely. And it does help. Same food, same time for naps, same times for their bath time. It does make a huge difference with toddlers. All children reach developmental milestones at the same age. Yes or no? Absolutely not. They're all different. That's why I love children. They're all completely different. Keeps me thinking. Immunizations for a 4-month-old infant, which action should the nurse take to provide ageomatic care for that infant? So immunizations, we're going to be putting it in the vastus lataris, right? In the upper outer thigh. And I don't care how much you prepare them, it's still going to hurt. I don't care if your parents are holding them, it's still going to hurt. We're going to give them a pacifier and put a little sugar water on it. There was studies done by Harvard pathophysiologists, I believe they were called. And they said that morphine works just as good as a little bit of sugar or sucrose on a pacifier. So my grandson was actually circumcised with only the pacifier and sugar water. And he cried briefly, but less than 15 seconds. And then he was self-soothing with a pacifier. So this pacifier is one of the key concepts of self-soothing for infants. They take away their stress, everything. That's the new belief in pacifiers. Which of the following immunizations can be administered to a newborn? Now you're going to see in your readings, there's 2 huge pages on immunizations. This is one of the ones that you need to know about. And it's usually administered at the hospital prior to discharge, or a minimum at the first doctor's visit. And it's hepatitis B. DTaP is at 2, 4, 6 months. Polio, MNR are later on, up to 15 months later. So hepatitis B, first immunization. Normal heart rate for an infant is It's 140 to 160. So then I'll ask you, if an infant is on digoxin, and they can be very safely, if they're on digoxin and the heart rate is 110, would you give it? No, you tell a physician. You see the difference between adults and children and why you need to know heart rates. Good. What is the preferred site to give an injection to an infant? And that picture, the way that person is giving it, I would never, ever recommend it. You need two people to give it immunization. I have seen children's needles scratch legs, and that would absolutely happen there. But it's called a vastus lateralis. In fact, my way to position is let the parents hold the child, hold that dye, and have another nurse there with me to be sure, and then give it. Because not all parents hold them as much as they actually should. The death of an infant under 1 year old with no known cause. Now, as I studied and became a professor of pediatrics, this is one of the things I didn't know, some of the risk factors. And one of the risk factors I never knew about was males are more common than females. And then as you read it, there's a lot more. Of course, smoking and co-sleeping and overheated, et cetera, upper respiratory infections. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why is she doing that? This is respect. This is all respect. And you know something, if I didn't know why, I'd say, ma'am, why don't you want to look at me? And I want to tell you, asking a person the reasons why they do things, they will have more respect for you because you asked. That means you cared enough to ask the question, because we're all different. We're all special. We're all unique. We all have our little different things. But to ask it, that parent will be honored to tell you. A child from Mexico is hospitalized for a serious illness, and the father says the child's being punished by God. Why? This is their belief. This is what they believe, that, you know, if you've done something wrong, that's why you're getting sick. It has nothing to do with normal sequence of events. So that's their belief. There's nothing you can do to change their belief. It's what they believe. Which term refers to a time in an individual's life when he or she is more susceptible to positive or negative influences? Again, this is another one of those terms. You know, you'll see in your book, the beginning page, you'll see all the definitions, something to look at in pediatrics. There's different terminology. And it's called the sensitive period. What is characteristic of the pre-operational stage of cognitive development according to Piaget? Again, I don't expect you to know it this week. Again, I'm introducing it to you. As you keep seeing it and hearing it, you'll understand it better. Now, developmenting cognitively in children, they need to see it. They need to see it to understand it. So thinking is concrete. They don't get it. There's no logic that can be made yet. There's no inductive, there's no generalizations. Okay, here is this car. It has wheels. So pull it back first and let go, it will roll real fast. That's concrete. They need to see it. And then they can build upon that with other stuff, but they have to see it. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? Now, this is what Kohlberg talks about, morality. And he says, there are good and bad things that you can do, but each one has a consequence. If you do something good, somebody's going to tell you, hey, you did a great job. That's a consequence. Or bad, that means there's going to be a consequence, maybe a time out. As they get older in age, into school age, they might do something bad knowing the consequence, but they want to do it because they have to. Even with that consequence there, they start thinking more logical about it. Let's see how we did today. Number 3, Mika, or is that Mika? Good job.
Mika.
Prescription and RX, okay. And Yvette, good job, guys. Number 4,
Hey.
Jill and Megan. Okay, before you forget, please sign the attendance attestation. You need 2 points of contact, and that is the second point today. Your discussion question and your attendance attestation. Anybody have any questions?
Would you say that if, now last term in maternity, we were told we really would not have time to read the book. We should basically concentrate on the lectures. Do you feel that same way?
I think your book is a great reference tool when you don't understand something. I would do your, the PowerPoints, your interactive lecture that's in your modules, and the Kahoots. Those 3 things have everything you need.
Okay.
Okay.
Good, thank you.
Your book is there as your guide. I don't get this. Let me read something more about it, and it might help you. Okay.
Thank you very much.
No, you're welcome. Anything else? We're done.